This is an interview with Dr. William Foege about his activities in the West African Smallpox Eradication Project. The interview is being conducted July 13, 2006 at the Centers for Disease Control and Prevention. It is a part of the 40th anniversary celebration of the launching of the West African Smallpox Eradication Project. The interviewer is Victoria Harden. Dr. Foege, to start with, would you briefly describe your childhood for me and your pre-college education, and who influenced you to go to medical school and get interested in public health? That's a flock of questions, but would you briefly summarize your growing up?
I started out in northeast Iowa and lived in a small town of 100 people. When my family moved away, the population went down 8%. And I went to a one-room schoolhouse for the first 5 years. We then moved to Chewelah, Washington, and I thought I was really in a big city. It was about 1,500 people.
And why did you move?
My father was a minister, and so he got a call to a new church in Chewelah, Washington, and we moved for that reason. And from there I went to Colville when he started a new church in Colville, and that's where I graduated from high school. I went from high school to Pacific Lutheran, what is now Pacific Lutheran University in Tacoma, Washington, and became interested in biology because of a very forceful biology teacher who was a man I've never seen the likes of. He would walk. His name was William Strunk, and he would walk into the room lecturing as he walked in. He would go to the board and actually write with both hands simultaneously, putting up phyla and families and classes and genus, and he would still be talking as he left the room. And so I ended up being a lab assistant to him, and then actually working at his place on weekends for doing yard work. And so that was an important part of getting me into science. My older sister, Grace, 4 years older, had gone to the same school and went to medical school, and that was an influence. But I was also influenced as a 15-year-old when I spent 3 months in a body cast, unable to turn over or do anything, and this was in the days before television, so I was doing a lot of reading, and began reading about Albert Schweitzer and medicine and Africa, and all of this became very interesting to me.
Had you had an accident, or?
I had a problem with my hip that required 3 months of immobility, and then the hope was that it would heal correctly, and it did, but always off a little bit. So, but it was a time of reflection and reading that I might not have had without that. In medical school, I began working after school and on Saturdays for a fellow by the name of Ray Ravenholt. Ray Ravenholt had been one of the first EIS officers, Epidemic Intelligence Service officers at CDC, and he was always pushing the idea of public health and the idea that I should think about the EIS at CDC. I went off to New York for my internship and had applied and was accepted in an internal medicine residency when I got a call from Don Millar at CDC, and he said they had just received some positions that they could expand the EIS class, and would I be interested? And so I abandoned my idea of going into internal medicine and went to CDC in EIS in 1962.
And had you always, because of the suggestion that you should do public health, been interested in public health, or were you that just kind of a sideline until you got to CDC and you thought you might actually do internal medicine?
Well, Ray Ravenholt was such a powerful influence on me that I was interested in public health by the time I graduated from medical school. And of course I didn't see exactly where I was going until Don Millar called and with this EIS opening. And then I never looked back. I mean, I was so pleased at CDC with the EIS program. I was assigned to Colorado, state assignment, and while there I did 2 overseas TDYs. One was to India in 1963, when at the EIS conference they announced that the Peace Corps physician in India had taken sick and it would take some time to replace him, and they were looking for a volunteer to go as the Peace Corps physician. This I did, and it turned out to be important in so many ways. I saw global health close up. I saw my first cases of smallpox. I made rounds at Holy Family Hospital in New Delhi. I worked for a man by the name of Charlie Houston, who was key in mountaineering. He had actually led a group up K2 in 1953, and before getting to the top, they were stuck in a storm, and one person developed deep vein thrombosis, and then developed it in the other leg. Charlie Houston said that they had to get him down, and everyone said, we can't go down in a storm, and he said it's his only hope. And so they attempted to rescue him in a storm, and as they were descending across an ice field at a 45-degree angle, one person slipped and fell, and this person ended up then getting tangled up in another rope, and now 4 people are falling, and they end up hitting Charlie Houston, who's on a 3rd rope, knocking him unconscious, and the 4 people plus the 3 on Charlie Houston's rope are all falling, and they're held by a man by the name of Peter Schoening, who with his ice axe was able to stop all of them. It's an incredible story.
It is.
And to make it even more incredible, 2 months ago I went to the University of Colorado, where they gave Charlie Houston at age 93 an honorary degree, and then I had a half-day program giving him an honor. And all of the survivors of that 1953 expedition were there, including Bob Bates at age 95, former headmaster at Exeter, Bob Craig, who was the youngest of the group and was now in his late 80s. And so it was a spectacular person to work for, who was able to demonstrate that you can work in a developing country and not get overwhelmed by it. That he was always got up every morning just happy to be working and was never overwhelmed.
Fascinating story. I believe that you also were involved as an EIS officer with the group that went to Tonga to evaluate the smallpox vaccine and the jet injector. Would you talk about that a bit?
The other overseas TDY that I did was to Tonga, a group headed by Ron Roberto, and the idea was to see, could you dilute smallpox vaccine and use it in a jet injector. Tonga had not done routine vaccination since 1905, so it was a virgin population that you could measure antibodies and so forth, and they were agreeable to this. And so the attempt was to look at what would happen with a 1 to 10 dilution, a 1 to 50, 1 to 100, and so forth. And it turned out to be a very good study that demonstrated you could dilute the vaccine 1 to 50 and that you would get uniform take rates. And to be able to use the jet injector where you didn't have to use technique and have it come out the same with every person, and it's easy to train a person to use the jet injector, it turned out to be a very important study.
May I ask you a very perhaps stupid question about the jet injector? How it worked. Did it actually touch the people's skin? And if so, did you have to sterilize it between uses? And I don't understand how you could do thousands a day if you had to sterilize between every one.
The jet injector nozzle actually did press up against the skin. At that time, people were quite sure that there was no chance of cross-contamination, that the vaccine came out at high pressure, We've subsequently changed our mind about this, and that's why we don't use jet injectors at this point. But one could actually do people almost as fast as they could walk by. It became a rhythm that you would grab the arm and that you would step on the hydraulic lever, and then you would shoot, and the person would continue on. You could do 1,000 people an hour. And I remember at one point doing a prison in eastern Nigeria where they had the inmates lined up and they were actually pushing them through by hitting them with sticks. And I did 600 people in 20 minutes, and because it was such a regimented line that you could just grab people and do them so fast. And at one point I recall doing over 11,000 smallpox immunizations in one day. So yes, you could do this very quickly.
Oh, right. Yeah, okay. Are we ready? Mm-hmm. Before we move on in your career, is there anything else that you would like to comment about in your EIS training here early at the CDC?
In those days at CDC, anyone in the EIS program saw Alex Langmuir as a mentor. He was a very powerful personality. He knew what he was doing. He was inspired and inspiring. And so I look back on those days as days where Alex Langmuir was reaffirming how important it was to do public health and how important it was to do global health. He was just interested in everything. And during that time, as an EIS officer, I read an article in the New England Journal of Medicine. It was called Questions of Priority, written by Tom Weller. I had no idea at the time that Tom Weller was a Nobel laureate, but when I read the article, I knew I wanted to know him because he was saying in the article things I believed. It was a commencement address to the Harvard Medical School, and he was essentially saying, you're only going through life once, you might as well try to get it right, and here you come out with all these skills and this knowledge, and you have to ask how you're going to use it. And think about using it in the parts of the world that can best use these resources. The developing world doesn't have the resources of skills and knowledge, and now that you've gone through, think about using what you've learned in the developing world.
Maybe I can digress here for one philosophical question. Here we are in the early 60s, and I have heard many people talk about going into the Peace Corps and other, I'm a child of that period too, and I remember the idealism. I don't see the idealism in the 1980s, 1990s in terms of kids coming through college. But this was an idealistic time in a variety of ways, and the idea that to get it right in life you went and served people is a very different idea from getting all you can for yourself. Would you comment on on the idealism of this period and your peers?
Well, the early 1960s turned out to be a very nice time to be growing up in the United States. President Kennedy did inspire people with the idea of the Peace Corps. And so people were thinking really in terms of how best to serve your country and how best to serve the world. And then to read an article by a Harvard professor saying the same thing, I decided that I wanted to get to know him. So I applied at Harvard and no place else, and I spent a year with Tom Weller.
And I understand you did this on your own rather than the CDC sending you, but you did get a Master's of Public Health, and this is what you went for.
That's right. CDC actually offered a career development program to me, which meant that I could have training paid for a number of years, and then I would pay back a certain number of years. But by this time, I already knew I was going to Africa or someplace else. I knew I wanted to go into the developing world, and so it didn't seem fair to have CDC pay for my education and then, even if I paid back a certain period of time, then go off. So I went to Harvard on my own. I did get a scholarship, but I went on my own, And it turned out to be everything that I hoped it would be. Tom Weller was an inspiring person. He had an inspiring group of people, including Frank Neva, who was my faculty advisor, the father-in-law of Peter Bell, who became president of CARE, the father of Karen Bell, who ended up teaching here at Emory University. And so it turned out to be a very nice time. Now, when Tom Weller retired from Harvard, it so happened that I gave the commencement address that year. And so I got out that New England Journal of Medicine article, and I read the portions that I had found so attractive before, and made the point that you never know what will ripple downstream from what you say or what you write. Well, Tom Weller got a standing ovation in the middle of my commencement address, and it sort of completed a circle. And I've remained in contact with Tom Weller, who's in his 90s, just as I have with Charlie Houston and some of my other mentors.
I understand that when you finished your training at Harvard, you joined a medical missionary program in the Lutheran Church, and that it took a bit of effort to convince them to let you do a public health mission as opposed to a primary care mission. Would you talk a bit about that and what you finally set up?
Let me mention one more thing about Harvard before going to that. And in one of Tom Weller's classes, we had to do an independent project and present it. I happened to do a project on the feasibility of smallpox eradication in the world. Had no idea that I would ever be involved in this, but I found it an intriguing topic. There was a person in this group, Yemi Ademola, who was the head of preventive medicine for Nigeria and had taken a year off to get a master's degree at Harvard. So Yemi and his wife Rosa were there, and he was part of that class. Yemi Ademola ended up, after graduation, coming down to CDC and talking to people about his interest in smallpox eradication in Nigeria. So this is a small aside. I then went, after graduation from Harvard, to Nigeria to work for a church group. My interest was that most of the hospital beds in Africa were actually provided by church groups. So they had a big influence on health in Africa. But almost all of them were involved in clinics and hospitals, not in community work. It's easy to see why that would happen, because church programs had found that medicine was a great proselytizing tool. And so people in hospitals and clinics felt real gratitude, and so it turned out to be a form of recruitment. I always felt that was wrong. I felt that churches should be working in Africa or other places because of what they believed, not because of what they were trying to get other people to believe. And I wondered what would happen if you could get this force looking at community medicine instead of hospital medicine. It takes a far different approach to things. Now, I must say that it made no difference that I actually went to Africa to try that, because there were other things happening at the same time that would make that happen. And that was the World Council of Churches had a Christian Medical Commission, and there was a fellow by the name of McGilvery who headed that up. And this is what he believed. And he was so influential that in a period of years, he got medical mission programs to change in three fundamental ways. Number one, he got them to understand they had to work under governments. Colonialism was over, and they now had to work under sovereign governments. Number two, he got them to work together. And they had been very competitive in the past. But he got them to work together so that in many countries you now had one person who was the coordinator for all Protestant work and another one that was the coordinator for all Catholic work. And at least in a few countries, those two sat in the same office. I mean, this was an incredible change. And number three, he got them interested in community medicine. So I could have saved my time. I didn't prove anything by going over, and it was happening anyway. But I did go over, and we were trying that. We would probably have spent decades working on this, except the war in Nigeria came, and it went through our medical compound within the first weeks.
Can I get you to slow down and back up just a little bit to tell me exactly where you were and what was happening and what you were doing when the war came?
I graduated from Harvard in 1965, and that summer we left for Nigeria. We went to a medical center that was in the eastern part of Nigeria, and in those days Nigeria did not have states. They had only 4 regions: the north, the east, the west, and the Midwest. We were in the eastern region. This was the region that was dominated by Igbos, and they would later form the Republic of Biafra. But we were in a minority area of the east, in a place called Goja province, up near the Cameroon border. And in this area, there was a medical center at a place called Yahe, Y-A-H-E. It was a crossroads town, and that's where we went. We spent the first 6 months living in a village in order to learn the local language, and it was an eye-opener because it was a village with no electricity, no running water, and no indoor bathrooms, that sort of thing. And so we had an opportunity to at least see what life is like in a village. We had a 3-year-old son at the time.
I was going to say, are you married with children at this point?
Yes. So I had wife Paula, who will be the next interviewee, and a 3-year-old son, David. And we had the naive notion that we would actually know what it was like to live in a village. There's no way to actually know that because we could leave any time. The people living there can't leave, and so there is a form of bondage that I don't think it's possible for us to understand. But we were trying to. And so we lived in the village for 6 months and then moved to the medical compound. And it was while we were at the medical compound that CDC asked if I would spend time as a consultant to the Smallpox Eradication Program.
This is before or after the revolution?
This is before the war breaks out.
Okay.
And so we had been for almost a year in Nigeria at the time that Henry Gelfand came to Enugu to talk to me about would I be a consultant. Our medical center was 90 miles from Enugu, the capital of the eastern region, but we agreed that for a period of 1 or 2 years I would work as a consultant on smallpox eradication, and then I would go back to the medical center on weekends, so I would try to do both things 90 miles apart. And we returned then in 1966 to CDC to take the summer course for the people who were first going out, which is the group now meeting. And it turned out to be a very nice time for us to be back because my wife was pregnant, and she delivered our second child, a boy, in September. So it all worked out that we came back here, and she had the baby in Walla Walla, Washington, where my folks were living. And I attended the summer course and then met up with her. Now, an interesting aside here, it takes a while to get a passport for a baby, to get a baby added to the passport. And I even contemplated taking a picture of any baby and getting this on the passport before ours was born so that we could move more quickly. And I did not take that route and showed more sanity than usual, and we waited, and I returned to Nigeria, and then she came over with the 2 children at about 6 weeks of his age.
These are the small logistical problems, personal logistical problems that we rarely think about.
Well, sometimes they turn out to be overwhelming. See, when I knew that I would be coming for the course, I bought tickets for my wife and for David, and CDC would send a ticket for me. We got to Lagos to board the flight, and my ticket had not arrived. And so I talked with the manager, Pan Am manager at the time, and he said, well, you're in luck because the plane is late by 24 hours, and so we have more time to try to get the ticket. But it was July 4th. That meant nothing in Nigeria, but it meant we couldn't get anything out of CDC. And so we went right down to the line the next day where we had tickets for them, no ticket for me. About an hour and a half before flight time, the manager called me in and he said, we haven't heard anything, but I'll tell you what I'll do. If you write out a check for the amount of the ticket, I'll put it in my desk drawer, and so I'm covered if I get audited. And I told him, I can't do that. I don't have that amount of money in my account. And so we were at an impasse, and finally an hour before flight time, he said, I'll tell you what I'm going to do, and I've never done this before. I'm going to give you a ticket. And he said, I'm going to have to write out the check if I get audited. And so he gave me a ticket, and we got in line. And now what happens, they said, oh, this ticket was for yesterday. And I said, of course it was. The plane was supposed to be here yesterday. Now I have to go back to the Pan Am agent and say they won't take this ticket. And he was exasperated by that time, but he got us through. And we got on the plane finally, and I had this feeling, now we can relax. And I actually said to my wife, isn't it going to be nice to get back to the States where things work? We get to New York, and it is so hot. It's now at night. We're 24 hours late. And of course, everyone's had to have new connections. And my wife and son have a new connection, and I don't, because I don't actually have a ticket. And so now this causes a problem. Well, they said they're going to put everyone up overnight, and we'll get out in the morning. So in this heat, and it was, even though we were coming from Nigeria, it struck me how hot it was in New York. And we're waiting for the bus to take us to the motel, the Travelers Motel. There's a Pan Am man there in a suit and a tie, and he's very efficient. And he picks me out, and he said, could you give us a hand? And then he picks another person out, and now I realize he's picking us for our size. And he takes us outside, and he said, the battery's dead on the bus, and would you help push it to get the bus started? And we do. And we actually push it fast enough to get the motor to turn over, and it takes. Now he calls for men first, and I'm wondering what's happening. And so the men, like sheep, get into the bus. It turns out the back of the bus is very hot, and so he's trying to save the front of the bus for the women and children. And I hear him say to the bus driver, now remember, stop at the first service station and put in 3 quarts of oil. And I thought, 3 quarts of oil? I mean, this is a real problem. So the bus driver says, yes, lets out the clutch, kills the motor. Everyone is told to stay on the bus, as hot as it was. He said, we have another bus coming that's going to push this one to get it started this time. And that's what happened. And again, he says to the bus driver, remember, 3 quarts of oil. We go down the highway, and it must be 11 or 11:30 at night now, and he pulls off to a service station, and he sits there for a moment, and then he turns around and he says, you know, folks, if I stop the engine to put in oil, we're not going to get it started again. And so off he goes into the highway, and the motor freezes up. And so there we are on the side of the road with the motor frozen, and he tells everybody to get off the bus because it's too hot to stay on. And he makes a phone call. And pretty soon this Pan Am agent comes screaming up in a car, and by this time he has his tie off and his jacket off, and he's starting to look disheveled. And so he says, don't worry, we have some cars and another small bus coming. And when the cars and the small bus come, he tells the women and children to get in the cars and the men to get in the bus. And the women and children do as they're told, except my wife, and she stays with me. And he says to her, I want the women and children, she said, the way things are going tonight, I may never see my husband again, and I'm not moving. And so we get on the bus and we get on the motel. But see, to have said, won't it be nice to get back where things were, and then run into this.
It sounds third world in New York.
That's right.
Absolutely. All right, so I still haven't heard, though, about the war in Nigeria that forced you to end the mission program and moved you into CDC. Can you walk me through that?
Well, in the last part of 1966 and the early part of 1967, there was a lot of tension in Nigeria, and the East kept threatening to form its own country. In retrospect, I suppose oil was behind this, but we didn't quite understand that at the time. But we continued working. In late 1966, one of the most important things happened to me. There were two very important things that happened in my smallpox time in eastern Nigeria. One was we attempted to do a mass vaccination program in a place called Abakaliki, and we were very successful, getting 93% or something like that of the population vaccinated. And we were pleased by this kind of coverage, only to have an outbreak of smallpox a few weeks later in Abakaliki. Now this we didn't think should have happened, because we believed in this idea of herd immunity and so forth. What was different about it was a religious group, Faith Tabernacle Church. All of the cases were in the Faith Tabernacle Church. They had refused vaccination. The outbreak, the disease had come probably from another Faith Tabernacle person outside of Abakaliki. But the point of it is, we found that there was no level of vaccination that was so high that you could exclude the possibility of smallpox. That's one thing that happened.
May I ask you this question? You said that your independent project at Harvard was to come up with a smallpox strategy, smallpox vaccination. Was that your strategy that was continuing on? Was it mass vaccination from that period?
Everyone in those days was thinking in terms of mass vaccination, and that's what I was thinking of when I was at Harvard, that right. If you got to a certain level of vaccination, you would make it so difficult for smallpox to right. be transmitted that it would just die away. That's what we thought. But then the other thing that happened was December 4th, 1966. It was a Sunday, and I got a radio message from Hector Ottemiller, a missionary, who asked if I could come to look at what he thought might be smallpox. We went to the area, and it was probably 6-7 miles off of a road, and we used Solix bicycles, which were French bicycles with a small motor on the front. They were so light that when you would come to a creek, you could actually walk across on a log holding the bicycle in one hand, and it turned out to be a very efficient method of transport. And sure enough, these were smallpox cases. It was so early in the program, we didn't have much in the way of supplies, and then I learned we wouldn't get supplies. And so the question we were faced with was, how would we use our small amount of smallpox vaccine most effectively under these conditions? Well, what we did was that night we went to a missionary's house, because they would get on the radio with each other at 7 o'clock each night to be sure no one was having a medical emergency. But with maps in front of me, I was able to divide up the area and give each missionary a geographic area and ask if they could send runners to every village in that area. And the next night, 24 hours later, we would get back on the radio to see what they had found. We did that, and the next night we knew exactly where smallpox was. And so our strategy was, let's use most of the vaccine in the villages where we know there's smallpox. But number two, let's try to prefigure the smallpox virus. I mean, we literally asked ourselves, if we were a smallpox virus bent on immortality, what would we do? And you have to find susceptibles to continue growing. So we figured out, where are people likely to go because of market patterns and family patterns. We chose 3 areas that we thought were susceptible, and we used the rest of our vaccine to vaccinate those 3 areas. And now we're out of vaccine. We didn't know, but in 2 of the areas, smallpox was already incubating. But by the time the first clinical cases appeared, those areas had been vaccinated, and so it went no place. The interesting thing was, 3 or 4 weeks later, the outbreak had stopped, and we had done such a small proportion of the population. So now you have this contrast of a Bakaliki with great coverage and a smallpox outbreak, and a Goja province with very poor coverage, and the outbreak stops. And we began to wonder, is this worth trying in larger areas? So we talked to the Ministry of Health, and it's a very crucial time because war is being talked about every day. And the Ministry of Health said, in the eastern region, they were willing to change the whole strategy, put all of our attention on finding smallpox and containing each outbreak. 5 months later, as war fever is now at a peak, we were working on the last known outbreak in that entire region of 12 million people. So in 5 months, we'd cleared out every outbreak. We're working on the last outbreak when war breaks out. Now, I didn't know war was going to break out at that moment. And the smallpox program had planned a meeting in Accra, Ghana, for the 1st of July, 1967. I went to the American consulate in Enugu and asked, what's the chance that there will be fighting in the next weeks? And they said, not a chance. They said neither side is strong enough at this point to actually initiate anything. But the border had already been closed between the east, which now called itself Biafra, and the rest of Nigeria. And indeed, 6 weeks earlier, we had sent our wives and children out. So we had actually gone to Port Harcourt, and our wives and children got on planes, and they were DC-6s, I can still recall, because it took forever for them to get off the runway, because every seat had an adult and a child.
Where did it go?
From Port Harcourt to Lagos. Port Harcourt was in the east, but they had received permission for people to fly out. So, as this meeting is about to start in Accra, Ghana, I determined from the consulate that we would not have to worry about fighting in the short term. And so we actually crossed the Niger River in canoes, or they were slightly big canoes, but there was no real border. And yet, we got our passports stamped on each side by people who were pretending that this was all legitimate. And then we got taxis from the other side of the river to Lagos, and then from there we got to Accra. We're at Accra at this meeting when the fighting breaks out. The American consulate had it all wrong. And so now we couldn't get back. And we did not know for months whether that last outbreak had actually been contained or not. It turns out it was. And so there was never any smallpox in the area of fighting during the Nigerian Biafran Civil War. And that turned out to be a real blessing. But think of how close that one, I mean, it was a window of opportunity that because of our December experience with the small outbreak, we went and asked, could we try this on a larger area? And in 5 months, we had cleared out smallpox from the entire region, and so it turned out not to be a factor in the war.
So you had this experience, and you knew that it could be done now to use this method of surveillance and containment, eradication, escalation, whatever term we were going to use. And at this point, you were asked to come back into CDC and came back to Atlanta, if you will tell me about that, and then you had to go sell this idea to people. And I want you to tell me about who you had to sell it to and what you did to sell it.
At the end of the meeting in Ghana, I wasn't quite sure what to do since the East was now closed because of the war. I went back to Lagos, and it was decided that I would work in northern Nigeria for a while. And I have to step back just a few weeks or a few months to say that on one morning in Enugu, a Saturday morning, we went into work and found that there were cases of smallpox in the hospital in Enugu. And suddenly we knew we had to do something in Enugu itself, and spent the rest of that day planning for doing vaccination in Enugu. That afternoon I went out in a VW bug and mapped out the places in Enugu where you had enough room that you could actually have people lined up to do vaccinations, and so figured out where we would have our vaccination sites. And I was not thinking of anything about except smallpox at that point. And suddenly I was surrounded by police. Someone had reported that there I was with maps, and of course that looked suspicious. So I was arrested. And it took hours before they would allow me to make a phone call. I wanted to call my wife so that she would know why I wasn't coming home for dinner. They would not let me do that. But they eventually let me call my counterpart, Dr. Anazanwu, in the Ministry of Health, and he came down and got me bailed out. I say that just to make the point that I had been arrested by the Biafrans. Now I went to work in northern Nigeria, and I was in Sokoto province, which is up in the northeast part of Nigeria, and had just set up a tent for the night and was getting ready to cook dinner when a pickup with a crew cab with a front seat, a back seat, and then a pickup drove up, and police officers got out, and a man came up to me, gave me a piece of paper and asked me, "Is this you?" And there was my name on the paper. And I said, "Yes." And he said, "Well, you're under arrest." And he would not communicate anything more, why I was under arrest. But I had to put everything together and get into the back of the pickup. And we started the long trip back to Kaduna. At one point, they stopped at a guest house in order to go in and drink beer. They left me alone, sitting in the back seat of that pickup with a pistol on the front seat. And you know you don't want to move at all, which I didn't. And they came back and we continued the ride. In Kaduna, I was put on house arrest. And after several days, they said that they would allow me to leave the country if I would never return. And so I left and flew out to Ghana. But a few weeks later, I was asked to go back to Lagos by the regional office. And so I thought, you know, I know the state of records. And I went back, and there was never any problem. So, but the point I make is I was arrested by both sides, so it showed my neutrality. Now I did end up going back to CDC, and I always expected that the war was going to be finished within weeks. And so that was my thinking. And when I returned to CDC, I came back as a contract employee for what I thought would be a period of weeks or months, and began working on the idea, could we use surveillance containment throughout West and Central Africa? And so that's what we worked on, selling the idea. Some people were sold immediately. I mean, I think of Don Hopkins coming in, going to Sierra Leone, having the highest rates in the world in Sierra Leone at that time, having poor communications and transportation. He started out from the beginning doing surveillance containment. He never bothered with mass vaccination, and it worked well. Other people were more reluctant And I can understand that because you've sold a government on this is what we're going to do. Eastern Nigeria had been easy to convert. They saw the logic, but it was not that easy every place. But gradually, place after place did do this. And the bottom line was we ended up having a goal of smallpox eradication in 5 years. We ended up having country after country with smallpox disappearing. And I'm quite sure in any geographic area where they converted to surveillance containment, 12 months later, it was free. So Nigeria had the last cases in May of 1970, but that whole 20-country area had smallpox disappear in 3 years and 5 months, a year and 7 months before the target, and under budget.
It's a fascinating story. But now, what I'm hearing is that each group in the field had to adopt this approach, that we don't have top-down. I was thinking that the order may have come from headquarters in Atlanta and told everybody to stop doing mass vaccination and start doing surveillance containment. That was not the way it happened.
It's hard to make that change when countries are autonomous and they have their own programs and they've now been sold on an approach. Now, Don Millar was an immediate convert to this, and he was in charge of the entire West Central African program. Mike Lane had a fiefdom, a region that he was in charge of, and he was an immediate convert. So right from the beginning, we were talking this up, and with each meeting, it was possible to demonstrate that this was working in some areas, and so gradually, everyone did come on board. But it took a little while. But nonetheless, to have it disappear in 3 years and 5 months, it didn't take long.
The program agreements then that were signed had the governments in Africa. It was outlined in those how it was going to be done, and that included mass vaccination. So that's what had to be shifted then, was the original agreement country by country. I see.
That's right. And to me, the strange thing is not that it took some period of time. The strange thing is how fast we absolutely changed strategy. I mean, just turned things upside down, and how fast that happened in 20 countries.
To me, as a historian, the fascinating thing is how that flexibility was embraced. So many times it's not embraced when somebody has a new idea and can demonstrate that it works, because people are so invested in the old idea. So I'm finding it very interesting.
Well, and see, this was part of the value of having such young people.
Yes.
And Julie Richmond, former Surgeon General, once said that the reason smallpox eradication worked is those people were so young they didn't know it couldn't. And you know, so people were very flexible. And when you think of the number of people that went from CDC into West Africa, most of them never having had experience in West Africa, and yet they adapted so fast. And I think when you look at the group as a whole, what characterizes them, I mean, everyone has mixed motives. It's hard to know what motivations are, and people often ask me, what's Bill Gates's motivation? And I say, how do I know? I don't even know my own motivation. It's such a mixture of things. So these were people that had a lot of interest in doing new things and exploring and so forth. But the thing that characterizes them, they were all problem solvers. You couldn't give them a problem that was so difficult they didn't want to try to solve it. And so they were very adaptable. When they had a new idea came out, they quickly used it.
In the middle of the West African effort, I don't know if you were involved in this back here at CDC, but there was a recommendation that smallpox vaccines be stopped in the United States, and there was a great deal of discussion about all this, and I just wondered if you were involved in that and can recount this, because I know they were not stopped in the U.S. until the early 70s, because I have a son who got vaccinated in 69 and a daughter who didn't in 73. But can you talk about the discussions about what to do in the United States?
I was involved during those years. 1971, we really did attempt to stop smallpox vaccination in the United States. And when you think of the courage, because there was still smallpox in Africa and in Pakistan and in India and Bangladesh, lots of places. But by then, the calculations had been done by Mike Lane and John Neff and other people showing what the risk was of the vaccine. And the United States had a risk of smallpox coming in, but we concluded that the risk was less than of the vaccine itself. And part of the reason is geography. Europe acted as a filter for smallpox cases. People coming from Africa or from India and Pakistan often went to Europe first and then to the United States. So Europe continued to have outbreaks and we didn't. But we calculated what would be the risk. For instance, if you look at ships, because of the time it takes to get here and so forth, we were able to calculate the risk of smallpox coming to the United States by ship was about 1 importation in 600 years. And it's far greater than that for airplanes, but it gives you an idea that it was possible to calculate based on what's the incidence in the country, how many people go from that country to the United States, and what percentage of them are probably not adequately protected, and so forth. And so that recommendation came out in 1971. It took quite a while before it was actually followed by everyone. But as part of that, we developed a plan for what would you do if there was an importation. And some of us went then to the states so that we got to every state and we used what was called the case manual, comprehensive action for a smallpox emergency. And in that notebook, you could pick out from the front cover a big chart that you unwind and put up on the wall, and it shows you every step that you have to take. And every step then had a place in the notebook that gave the details. So our point was, you don't have to study this ahead of time. You just have to know that it's here and what steps to take if you think you have a case of smallpox. I think that was very important because then you would not have panic at the time that this happened. There was a very clear chart to follow. So we did that at the time. And I really think we did a good job at educating the state health officers, the state health programs, the counties and so forth on what to do in case of a smallpox case.
I want to talk about the period after zero pox was achieved, but I should ask you before we get there if there's anything else you would like to talk about in the West African program per se.
I think we've covered the main things, and the only other things I had were stories of various kinds, but I don't think they're as important as the big picture. So.
All right. Before we turn to the period after the program, I think there might be a couple of stories that we have not covered during the West African program. Could you tell me about these?
The program itself, as you can imagine, was very difficult. Communications were bad, transportation is difficult, it's oftentimes hard to get food. I mean, it was not an easy time. And then to be in an area that civil war was about to break out, and the tensions, and to have roadblocks where teenage boys with guns and drinking beer were making decisions, this was very difficult. And
were you afraid?
You always had to be a little bit afraid of a teenage boy with a gun who's drunk. I mean, because they do irrational things. And so, yes, you never wanted to talk back. And some of the stories of that time, one woman, as she had her car examined, they looked in the boot or the trunk, and she had a labeling machine. Well, it looks a little bit like a pistol, but not much like one, but they were curious what that was about. And so she explained that it would make their name, and then she showed them, and they spelled out their name, and she made a label for them. she continued down the road and heard a rattling in the trunk of the car. She stopped, and there were 3 guns. Each one had taken their label and walked off with it, leaving their gun. And she drove back, and of course these people were very nervous, thinking a commanding officer was going to come by, and they didn't even have guns. But you worried about the roadblocks. One of our people, as the wives were leaving from Port Harcourt, had gotten a little upset with a guard who asked them once more to open the suitcase, and he said, "We've already opened it," and the guard did not like his response. Next thing, he had him in a room with a guard and a gun. And this person realized then that he had the key to his wife's suitcase, and they were asking her to open it, and she couldn't. And so he asked the guard, "Couldn't I just go out and give her the key?" And he said, "No." So he said, "Well, what would you do if I just stood up and walked over and gave her the key?" He said, "I'd shoot you." And so my friend stood up, and the guy cocked the gun. He sat down again. And then he asked me to come in, and I talked to the guard and asked if I could give the key to his wife. But he never was able to say goodbye to his wife even. So, you know, you just did not want to fool around with people. Well, one day, there I am in one of these big green international vans, and we're driving down the road, and there's a checkpoint up ahead. And the driver, just the 2 of us in the car, the driver started putting on the brakes, and the brakes had gone out. And so he pulled the emergency brake, and there was no emergency brake. The last thing he's going to do is go through that barrier. And so he goes off the road, we go into the ditch, we bounce around, we hit a tree, and we come up against a building. And suddenly we're surrounded by people. And this is the thing in Africa. You think you're out in deserted land, and as soon as something happens, you're surrounded by people. It took a while for me to realize what was happening, but the chief came, and he was a real orator. And he began telling me what we had just done. And he said that that tree was a juju tree, and that we had offended it by knocking it down with our vehicle. He would have to do a sacrifice. He would sacrifice a chicken. The chicken would cost 10 shillings. And, you know, when he was all done, and it took him a long time to get to that point, when he was all done, I breathed a sigh of relief, because I didn't know what was coming. 10 shillings, that's nothing. But then something very perverse took over in my mind. And I began talking back in the same way that he did, and telling him that I understood all of this, and that, yes, we had our own kind of customs where I came from. And where I came from, this vehicle was considered to be a juju god that had been very offended to have that tree there, and I would have to sacrifice a goat, which would be 20 shillings. And then I pulled out 10 shillings and asked, who do I give the 10 shillings to, and who will be giving me the 20 shillings? There was such a silence that I knew I had made a mistake. And just deathly quiet. And then one man started laughing. And with that, a few others, and pretty soon everyone was laughing. They saw the joke. No money changed hands, and we got out of there.
Wonderful story. I would also like to ask you how, when you have lived like this in Africa, do you readjust to living in suburban U.S. with all the fast food, with all the affluence? Do you have any thoughts on that while we're here?
It's an interesting experience to live overseas, and many people find it a great experience because they have servants, they get privileges that they wouldn't. We didn't quite have that experience, having started out in a village, and where living was very difficult, and much of your day was consumed in just boiling water, and we didn't have electricity, and couldn't even have a fan for the heat. And despite the difficulties, it was hard to come back. Suddenly everything seems too easy. But there's a good part of this. When we were using many CDC people in India on 90-day TDY projects, I got a letter from Don Millar, who was providing a lot of the people. And he said, I don't know if they're helping you at all with smallpox eradication, but keep asking for them, because they come back different people. And they have now experienced what it's like to have real problems. And they don't put up with a lot of the things in the United States. They just steamroll over them because they're not going to put up with that sort of thing. So there are good points and bad points, but living overseas is a broadening experience, and I just think it's so important for people to have that experience, and they come back with, yes, it may be difficult to come back, but they come back with a different perspective of how fortunate they have been.
Well, okay. When zero pox was achieved in West Africa, the outside funds for the CDC efforts pretty much dried up, but Dave Sencer was unwilling to let the program die, and he appointed you to be head and sent you out to ensure that the worldwide effort was going to be successful. Can you tell me about this transition and what actions you were taking after that?
There were two things that happened after smallpox disappeared in West Africa. One was this was always a smallpox and measles program. Measles was a major cause of death in West Africa. And it's interesting that USAID, which the funders for the program, always referred to this as the measles smallpox program. CDC always referred to it as smallpox measles, not because smallpox was more important than measles, but because it was part of a global effort, and eradication turned out to be so important in our minds. If we didn't achieve this in West Africa, the global effort would not have succeeded. And so at the end, we just assumed that USAID would see the benefit of the measles part of this, because measles deaths had been greatly reduced. Hospital beds that had been taken up by measles cases had now been freed up for other things. We had no idea at that time that they were being freed up for AIDS in the future, but that's what happened. And so I was very surprised and shocked when USAID made a decision to stop the measles part of the program. It was, and I still think it was, very short-sighted to get West Africa somehow addicted to measles vaccine and the reduction of this terrible plague, and then to say, and we're going to stop it, and now you're on your own. And we tried so hard to get that either continued or tapered off over a sufficient period of time. But
was that a decision coming down from the political administrations in the 70s?
It was a decision, as far as I can tell, of one person at USAID who was new and didn't have the emotional commitment to this and wanted to do his own things. And so that makes it extremely difficult, and as hard as we argued, we could not get over that. You do remind me, though, of one other thing where, in the attempt to get them to continue, I actually wrote a letter for Dave Sencer's signature to go to the head of USAID, which hopefully would put some pressure on them to continue the program. And it went to someone in USAID who sent it to me for a response. And that's when I realized how much fun government could be, when you can send your own letter and respond to it also. At any rate, the other thing was now to look at the rest of the world with smallpox eradication. And we were very concerned about India. And India turned out to have more smallpox. It was more intense than anything in Africa, although we didn't realize it at the time. They had had smallpox eradication efforts for decades, really going back to the early 1800s. And somehow it never quite worked in India. And so finally, speaking with Dave Sencer, we made a decision that I would go to India and first a reconnaissance to see whether it was possible to do something there. And in the summer of 1973, I went to India and spent time with their Ministry of Health people, with the regional office for WHO, and we concluded that I would go to India in August and September of 1973, and so that turned out to be the next venture. And India was, in many ways, so much more difficult than anything we had in Africa, and yet, once we got the system going, and I consider the peak of smallpox to have been May of 1974, when we had the highest rates that India had seen for decades, so much higher than anything we had suspected we would have, that I recall in the fall of 1973, D.A. Henderson asked me, what's the largest number of cases that you can expect in any week in any one state next year in India? And we did some calculations and decided it would be about 300 or 400. So he said, just to be sure, we're going to program our computers with 4 digits, not with 3. And I recall in May of 1974 having to call him and say that in Bihar, in 1 week, we had over 11,000 new cases of smallpox. I mean, it's just overwhelming. But we went from that in May of 1974 to 0 for the entire country of India in 12 months.
Using the same surveillance containment.
Using the same surveillance containment, which many people did not think would work in India because of the population density and the high incidence of smallpox, that you simply couldn't do that. And yet, in 12 months' time, once we got it geared up to have really good surveillance, and I'm talking about surveillance that was so good that every 3 months, we would visit every house in India looking for smallpox, and we would do it in a 6-day period of time. So in 6 days, 100 million homes would be visited to see if there was anyone with smallpox. And this was before computers. Mm-hmm. The logistics of trying to get people to 100 million homes in 6 days, and then finding on evaluation that over 90% of those homes had actually been visited. I mean, you can tell the effectiveness of the Indian bureaucracy once they commit to something.
That's very interesting. So you were working with the Indians then, and they were going into the homes. I mean, this is a huge manpower and management sort of thing.
It required, in those 6 days' time, to mobilize lots and lots of the health workers, take them off other things for 6 days, but it meant also hiring a lot of day laborers in order to get the workforce to do this. And the interesting thing for me in India was how we did not have the government of India and WHO and other groups. We were working so closely that in retrospect we've gotten together to talk about this, and people in the government say they never would have made a decision without our agreement, and we felt the same way, that we would not have made it. We were working so closely together, and I think part of the reason we were able to do that is we started traveling by train together, which means being overnight in a compartment and talking in a way that you never would going into someone's office for an hour meeting. I mean, you really are in this together.
That's very interesting. What impact did your years in Africa and India and the smallpox program in general have on your family?
I think the family saw our time in Africa and India as interesting times. I mean, our children often look back on India as something they really enjoyed doing. For birthdays, the person with the birthday gets to choose where we go for dinner, and inevitably they want to go to an Indian restaurant. I mean, that's just the way they feel about the place. I took one of my sons back when he was 18 for a meeting. It was in Udaipur, and we decided, rather than fly down from New Delhi, that we would experience India again. And so we hired an ambassador car and a driver and began the 13-hour trip. This is in July, where it's very hot in India. And I recall 2 hours in the trip saying to myself, this was a mistake. It was so hot. And of course the windows had to be open because we didn't have air conditioning, and the diesel and the exhaust and the dust coming in. And I looked over at my son, who has sweat rolling off his face, and I asked, Michael, how are you doing? And he looked at me and he said, you'll crack before I do. I mean, they just enjoyed India. And it's given every one of them a feeling about the world that I like to see, that they are concerned about the developing world. They're concerned about the inequities that one sees in this country and between this country and other countries. And so they're very sensitive, something that I think I attribute to having lived in other areas.
Did any of them follow you into a medical career or public service or public health?
Two of them are teachers, and I consider this to be even more difficult because you don't get compensated. I mean, what we pay teachers is a crime. And the third one went into anthropology. So all of them have this feeling. Yeah.
Before we stop, is there anything else that you would like to add?
Some of the tough, when I see war around the world and the fact that we have over 100 conflicts going on at any one time, and if you're not actually in the area, for us it's just a news story. And when I think of what it was like during the Nigerian Civil War and the kind of devastation and people starving, I mean, people actually starved during that war. And I went back working in the relief action and went into one town where you actually had to step over dead children as you walked down the street. Now, you know, this is not the way the world should be, and yet we don't seem to learn. It's how do you actually get people to make eye contact with this sort of thing, what's happening in Iraq right now that shouldn't be happening at all? How do you get people to make eye contact and know that this is absolutely the wrong way for us to be living?
I'm going to say thank you for a very, very fine interview, and I hope that perhaps we can continue this conversation about later parts of your career, and informally I will give you my thoughts on your last question later in this weekend, I hope.
Great. Thank you. I appreciate it.